Hi everyone and welcome to the webinar. Okay everyone, welcome to the webinar. Tonight's webinar is on reducing opioid harm and on pain management. And so tonight we've got Q&A enabled. So Tracy, if you just move forward a slide. If you've got any questions, please include them in the Q&A box. So down in your menu, click Q&A and you can type in a question. Otherwise, you can put any comments in the chat box. And questions will be addressed during and at the end of the webinar. And tomorrow you'll get an email with links to the recording of the webinar and to a survey. And if you can complete that survey, particularly if you want to claim your PDP hour. Just a couple of quick tips to get the best experience. Make sure you close any other applications you've got running on your computer that might be using up some internet bandwidth. Get as close to your wireless router as you can. Obviously plug in your internet Ethernet cable if you can. And of course, minimize other people using the internet in your house and watching Netflix in the next room. And if you do struggle a bit, the first option is to turn off your camera. And if you do really struggle, you can go down to your microphone button and you can even dial in by phone. With that, I shall hand you over to Dennis Passion, who will be hosting for the night. Over to you with your mic on, Dennis.
Numero uno, thanks Lex. Welcome everybody and thanks for attending tonight. I think you'll find we've got a very current and very interesting program set up for you with some very good speakers. But firstly, I'd like to welcome everybody and pay our respects to the local Indigenous people, people of the First Nations, their elders past and present, offer our respects. The questions tonight, please, as Lex said, put the questions into the Q&A, which I believe at the moment hasn't opened yet, so it will open up. It hasn't been opened, but when it does. We have two very good speakers tonight. Firstly, we have Associate Professor Malcolm Hogg, who's the Head of Pain Management or Pain Services at Melbourne Health. He's a clinical associate professor at the Faculty of Medicine, Dentistry and Health Services at the University of Melbourne. He's also a current board member of Pain Australia and was a past president of the Australian Pain Society and contributed to the development of the National Strategic Action Plan for Pain Management. And he's a member of the Opioid Regulation Advisory Group from a Therapeutic Goods Association. He has many state leadership models and has a wealth of experience in independence programs and in pain management services and models of care consultation processes. Our second guest is known particularly to the rural doctors in New South Wales, Lewis Christie. Lewis is the Palliative Care Services Medical Officer at Western New South Wales Health, based in Orange. He first arrived as a rural cadet in 1994 and obviously hasn't emerged too far from his home base. He became Director of Medical Services in Orange in late 2006. He's held that through the development of the new General Hospital complex until 2012 when he resigned the post to return to clinical medicine. After a brief stint in general practice, he's worked full-time as the Palliative Care Service Medical Officer in the Health Service District in the Eastern Sector and has an intense dislike of administrative medicine and a strong preference for clinical medicine. So he's learned the ropes in a hard place. So we'll start off with Lewis. Lewis, if you'd like to start off with your presentation. Thank you very much. Can we have Lewis's presentation?
Thank you. So we thought we'd first of all talk about some of the regulations that have come in recent times, but also look at the regulatory background generally speaking. Part of the reason for that is that one of the anxieties that I'm regularly met with from other clinicians, other prescribing doctors, is uncertainty around what the regulations mean, uncertainty around whether or not they're legally able to prescribe things, and sometimes uncertainty about whether or not by prescribing any sort of opioid they may be leaving themselves open to deregistration. So I thought we'd talk briefly about the regulatory environment before we move into the clinical stuff. So can I have a look, next slide, please? So really the question I'm hoping to answer for you is the question that comes up fairly regularly for me. What are the restrictions? And occasionally, recently, we've had some issues with people saying to their patients, look, I just can't prescribe opioids now, the specialist will have to do it. And so that creates a whole lot of challenges, and it's not correct. So if we move to the next slide. So there are two levels of restriction in place. There are national regulations and there are state and territory regulations. The recent focus has been on the national regulations, obviously because they changed on the 1st of July. June, July. But the state and territory regulations also sit in the background, and you need to be aware of those. So if we move on to the next slide. So the national regulations are overseen by the TGA. The focus of these is on the use of opioids as part of a multimodal treatment regime. So the regulations are really designed to look at how opioids should work within a multimodal treatment regime rather than being an isolated treatment. They focus on the use of opioids for acute severe pain. They underline the very limited role for opioids in chronic non-malignant pain, but note that there are some exceptional circumstances where they may be required. They also look at the longer-term use of opioids in malignant pain, and the regulations, and particularly the recent changes to the regulations, make a very clear distinguish very clearly between short-acting opioids and the sustained release preparations. So the next slide. And they achieve this, or they've managed to achieve this through a number of changes, particularly some of the recent changes. So recently, all of the PBS listings and authority requirements have been updated, and they're now much more detailed than they were previously. There's been an introduction of smaller immediate release pack sizes, so packs of 10 tablets for short-acting opioids, and that's really to provide specifically for those people who have short-term severe pain. You should note that the older pack sizes still exist to be used primarily for cancer breakthrough pain. There's an improved labelling and warning and product information available. There's a clear statement in the new regulations that slow release preparations are not to be used and not appropriate to use as a PRN medication for pain. There are some increased notation around restrictions on the use of hydromorphone and fentanyl, particularly in opioid naive patients, because these are particularly dangerous because of their potency. And there's an addition of a fair bit of detailed clinical information into the PBS. So if we go to the next slide, I've just cut and pasted a bit from one of the new indications in the PBS. The type is fairly small, but hopefully you can still see that on the device you're reading. It can be a bit daunting when that first pops up in front of you on the clinical screen in the consulting room with the patient in front of you. But if you read through it, what it is doing is describing the types of patients for whom opioid analgesia may be effective and the clinical indications for which opioid analgesia should be used. And also they stipulate the sort of steps that we have to go through before considering the use of opioid analgesia. You'll notice that there are very clear indications around when authorities will be provided for increased maximum quantities or repeats, and there are 3 or 4 conditions there that are, and although there's a fair bit of word, the descriptions are fairly detailed, they're actually quite straightforward. We're talking about people with proven malignant disease, chronic disabling pain where PBS, opioid analgesic treatment, is either less than 12 months, and we're anticipating that it'll be less than 12 months, or if the treatment has gone on for more than 12 months, that there has been some thought and some work to confirm that the opioid is required in consultation with another medical practitioner. It talks about opioid, the process briefly of obtaining authority extension. But generally speaking, if you read through those regulations, they aren't that onerous. They require some clear clinical thought, but they're not particularly restrictive, really. So if we move to the next slide. So we then come to the state and territory regulations. Now, it is worth noting that the state and territory regulations are completely different to the national regulations. They are generally more restrictive. They have more requirements for people to jump through. The focus is more directly on demonstrating harm avoidance and a risk management in clinical practice. And the other thing to remember, you know, one of the joys of living in Australia is that every state does its own thing in a different way. All of these regulations are different. So you need to be aware of the particular regulations in the state or territory in which you're working. It's important, if you're not aware of them, that you spend some time becoming familiar with them, because these are required in just as clearly as the national regulations are. So your compliance with them is just as important. So if we go to the next slide. So the state and territory regulations all require some form of authorisation from a state regulatory body to approve treatment involving patients either with identified drug dependence issues or for any patient in whom we're considering longer term therapy. And that's the briefest summary of that, and that's the commonality of all those state regulations. They're looking at making sure that drugs are not diverted, that drugs are not inappropriately provided for people who have a dependence issue, and that patients who are being medicated with opioids in the longer term, there is some oversight of the use of those, and there is a structured clinical plan. So generally speaking, regardless of which state you're in, a good approach to working your way through the state and territory requirements is to ask the questions: is this patient opioid dependent or at high risk of dependence? And is the proposed treatment likely to extend beyond a relatively brief period? If the answer is yes to either of those questions, then it's very important that you go back and look up and are familiar with your state and territory regulations. So I'm now just going to skip through some of the very briefly, some of the ways that those regulations vary from state to state, and you'll see some common themes, even though the regulations are written slightly differently. So if we go to the next slide, and the only way to do this sort of thing is alphabetically. So if we start with the ACT and work our way through to WA, you'll notice at the top of the slide there are some contact details there for the relevant service in the state, and they will always take phone calls, they'll always answer emails, and most of them have a website, though I haven't put those up there. So in the ACT regulations talk about drug-dependent persons, and they have a definition for drug-dependent persons there, which I won't read out, but anyone who fits that definition you have to obtain an authority to prescribe any S8 medication for them. Authority is also required for any treatment of any individual with opioids if the treatment exceeds more than 2 months. And that includes treatment by other prescribers. So if we're looking at someone who we're thinking is going to be on opioids for at least 2 months or more, then you need to get an authority from the ACT local government to do that, from the ACT Health Service. So if we move now to New South Wales. So New South Wales has a slightly different definition of a drug-dependent person, or someone who's at risk of drug dependency. And these are all taken from the relevant state and territory legislations. Again, they're fairly simple to apply. And again, authority is required for treating any drug-dependent person or for treatment of any individual if the treatment is going to last for 2 months, including treatments by other prescribers. There's a little note there to remind me to mention to you that in New South Wales, some benzodiazepines are also subject to the same requirements. And so if you're looking at having someone on some of the long-term benzodiazepine medications, you also have to obtain an authority from New South Wales Health. Next slide. So we move up to Northern Territory, and in the Northern Territory, where you have to put up with crocodiles and sharks and blue bottles and stingers, they don't tend to mince their words. So the Northern Territory legislation doesn't talk about drug-dependent people, it talks about addiction. And they have a definition of addiction again in the regulations. And again, in the Northern Territory, there is a slightly different system. So a doctor is required to notify the Medicines and Poisons Control Centre if they're proposing treatment of more than 8 weeks in total in the previous 12 months for someone with opiates. They're also meant to notify, or they're required to notify within 2 weeks of a dosing increase, or if there's a 30% dosing increase in any one interval. And there are specific initial and maximal dosing limits that apply. So there's more regulation there in the Northern Territory. The authority in the Northern Territory is actually given to the doctor, not to the patient. So if we have a doctor in the Northern Territory who is prescribing S8 drugs regularly for more than 15 patients, they have to be authorised to do that. So you can see again that the system is slightly different, but the intent is similar. So next slide. If we come to Queensland, again, we're talking about drug-dependent persons, and there's a very clear definition there of what a drug-dependent person is under the legislation in Queensland. And again, the system is quite simple. If you're looking to prescribe for anyone who you believe may be drug-dependent, you need authority, and you need to get a report for approval. Also, if you're looking at treating anyone for more than a period of 2 months with any sort of opioids. If we move now to South Australia, I think comes next. So South Australia has a slightly larger definition of people who are dependent on drugs. And again, an authority is required for treatment for any individual for more than a 2-month period, including treatment with any other prescribers. So we now step through again to Tasmania, where again, the Tasmanian regulations are again slightly different. Tasmania contains definitions for both drug-seeking behaviour and for drug-dependent persons. And it makes the definition, or makes the clear point, that drug-seeking behaviour includes people who are drug-seeking on behalf of others. So it specifically in the legislation talks about people who we believe may be diverting medications into the black market. And again, if you wish to prescribe for someone who has either of those issues, then you need to obtain approval first. And if you're looking to prescribe for anyone for more than 60 days, then you need to obtain an authority for treatment before the 60 days has occurred. And again, in Tasmania, there are similar regulations around the prescription of some benzodiazepines in the long term. And then lastly, or almost lastly, we come through to Victoria. In Victoria, there is, under the legislation, no current definition of drug dependence, but there are some, the Drugs and Poisons Regulation talks about doctors making a clinical decision around a patient based on flags which may indicate either drug dependence or rather than pharmacological tolerance. And again, a permit to treat is required if you're looking to treat somebody who you suspect has issues with drug dependence, or if you're looking to treat someone for more than a period of 8 weeks continually. And again, in Victoria, there are also regulations around the use of long-term benzodiazepine medications. And finally, in WA, again, there's a definition of a drug-dependent person. Similarly to the situation in Tasmania, the legislation in WA talks about an oversupplied person, which is a polite way of saying a person who's obtained more medications than one would reasonably think they could need. So again, looking at people who are diverting medications to the black market. And if you have either of those people in, or a patient with either of those concerns in WA, again, you need to obtain approval before you prescribe. And then although there's no time requirement in relation to an authority, doctors working in Western Australia have entered into an S8 treatment contract with the patient by 30 days of continual treatment. So you've got a month to establish a treatment plan with the patient around their ongoing opioid use, and maximal dosing limits apply. So all of the state-based legislations look slightly differently, and that's a very, very brief summary of the major points. The important thing to be aware of is that those regulations exist, and that if you are looking at prescribing for anything more than a very brief period of time, you need to explore ahead of time what is required in your state to prescribe, so that you can ensure that you can legally obtain prescriptions for your patient, and that you don't end up in a situation where you're in breach of the local state-based regulations. So next slide. What does this all mean for me? Well, what it means for us as doctors is that the regulations, and the regulations particularly that have been tightened a couple of months ago, really just reflect the principles of good clinical medicine and current evidence around the use of opioid medications. They endorse the use of opioids for acute severe pain, particularly post-operative pain and trauma for a brief period after surgery or trauma. They endorse the fact that slow-release opioids should not be used on a PRN basis. And in the use of chronic pain, they endorse the need for us to consider non-pharmacological treatments, to focus on the presence of function rather than the absence of pain often, to look at using the WHO pain ladder, so escalating our analgesic regime. And they also acknowledge the greater role of opioids in pain associated with malignant disease. And next slide. The regulations are not intended to result in rapid opioid deprescription. I've had a couple of concerns locally from patients who've been on long-term opioids who've been told that, well, we're just going to have to take you off them today because the regulations say I can't provide them to you anymore. That's not the intent of the regulation, and one of the reasons that there is the exceptional circumstances in the clause in the regulations is to give people an opportunity to sit down and look at patients who've been on opioids for a long period of time and negotiate with them a different strategy for managing the pain if they believe that those opioids are no longer appropriate, or to review the circumstances and to obtain some clarification around the ongoing use of opioids if those are appropriate. The regulations aren't intended to just cause a shift in prescribing patterns from one set of medications to another. And I've noticed locally in our practice that we're seeing a lot more people who are being put on larger doses of pregabalin and gabapentin particularly, not necessarily with clear clinical indication other than they have some sort of pain. And so it's not intended that we're going to swap one type of prescribing for another. And definitely the regulation's not intended to leave patients in terrible pain with nowhere to go. So next slide. And this quote comes directly out of the TGA's webpage in relation to their information for health professionals around the prescription of opioids. And it notes that the regulatory changes will not lead to a ban on prescribing opioids to any category of patient if ongoing use is considered to be clinically appropriate. The changes will prompt prescribers to reflect on their opioid prescribing practice, to ensure that when either initiating or continuing to prescribe an opioid, they have a discussion with their patient and consider whether they would benefit from opioid treatment and how the risks and harms of that are managed. Medication is only one potential component from a multimodal plan of pain management, which also takes into account a person's social and psychological background. So the aim is not to prevent us from using opioids where they're clinically indicated and appropriate, but to support us in making robust clinical decisions using the available evidence around how we treat people. And that brings me to the conclusion of the discussion about the regulations and the recent changes.
Thanks, Lewis. Much appreciated. We've had a couple of questions. We might, as time's tight, we might wait till the end for questions. We might leave the cases if we need them. So I might, thanks again for that. That's a good overview. I will ask Malcolm Hogg now to come on and present his summation. So Malcolm, if you can take over, we'll see how we go. Thanks.
Great. So I have actually, that may or may not be my screen there. That's the one. So thank you for the invitation. And I suppose I want to just add that I initially was a ruralist as well, in that I was born and bred in Mount Gambier and grew up there and then went to university in Adelaide before my medical practice in Melbourne. So for some reason I've lost that again. Okay, so it doesn't look like my screen is willing to be shared.
Oh, I can see it at the moment.
What you're looking at, I think, is still the other screen, right, which is the PDF of what I'd referred, I think.
You can just use the PDF if you like, Malcolm. If you do Control L, it'll make it full screen.
Hang on, I think I've got it now.
Yep.
There you go. That may be.
Yep.
No, that's still the other one. Okay, that's fine. I'll there's a number here that I wish to go through. I'll jump through, so I will bypass some of these if you wish. So this is really the basic of the nociceptive concept, that nerve activity in response to tissue trauma leads to activation in the brain in three major sites. There's a sensory component, but there is also clear activation of brain sites associated with emotion and meaning. And that means that pain is actually a multidimensional experience, and that's the neurological basis for pain. I'll go to the next page. And so clinically, what we see more than just nociception clinically. We see a clinical concept of sensitization where we get peripheral upregulation from a tender wound, for example, or we have problems of upregulation of the spinal cord. And there's a third group where there's sensitization happening in the brain, and we can refer to that as tertiary hyperalgesia. And we might see this in someone who's been traumatized. So the refugee group that have got a torture history, they have a primed cortical area, and so they respond to a greater extent to stimulation with a new onset of trauma or injury. Following on from nociceptions, there's a response. The brain should respond in trying to suppress the pain and do something about it. So clinically, this is behavioural, in that we avoid the cause of the trauma, but it may also be physiological in changing our heart rate, our blood pressure, and neurologically, we try to suppress the pain experience. And one way of testing ability to suppress pain is through conditioned pain modulation. And so this is where, and the diagram on the right looks at an experimental pain experience, and then on the opposite side, placing it into a conditioned pain modulation stimulus, the blue line, which in this example above is a cold bucket of ice water. And that will activate the descending systems releasing opioids in the brain. And our ability to downregulate is predictive of how we respond to pain after surgery, and if we're in a higher risk category to develop chronic pain. So military personnel, triathletes and others have very strong conditioned pain modulation systems, whereas those with high levels of anxiety, trauma or catastrophizing. Some genetic groups have lower ability to downregulate pain. So this means that a person's neurological nociceptive spectrum can direct you towards understanding their pain experience. We go to the next slide. And there are a number of factors there that link into this, demonstrating that those that have poorly controlled acute pain are at higher risk of developing chronic pain, but then the other factors contributing are psychosocial in nature, but they have a neurological basis. So people with genetic risk factors, with a family history of pain condition, those that have been traumatized through childhood or other traumas through adolescence, those with past pain and high levels of anxiety or distress. And the last one there is compensation or solicitous systems. So someone in workers' comp or have suffered significant injustice with the cause of their pain, then they are at higher risk of developing chronic pain through this brain mechanism. We'll go to the next slide. And this is links to this fear-avoidance model about someone who goes from acute pain, trauma, a nociceptive experience, to someone developing chronic pain, in that most people have risk factors that are either positive or negative. Not everyone has all negative and not everyone has all positive factors. So we really need to understand these risk and vulnerability factors and try to manage them, but also promote those that encourage recovery and reduce the risk of developing a fear avoidance disuse cycle. We'll go to the next slide. When we then look at someone with pain, we should be trying to think about classifying it as to duration, mechanism, site, or the cause. And that's what we do in a very descriptive manner. But we can also look at it as the driving force of what's the predominant mechanisms or the combination of mechanisms in their pain experience. So nociceptive pain really looks at people who've got ongoing activation of their nervous system due to structural problems either in the somatic system or the visceral system. Those with damages to the somatosensory nervous system can present with neuropathic pain. And then there's this third group, now referred to as nociplastic pain, which really looks at that sensitization component, where there's a change or an upregulation of the somatosensory system. And this can be, like mentioned, peripheral, in the spinal cord, or at the brain level for hyperperception. You do get sensitization in pretty well all chronic pain states. So even though they might have a nociceptive source such as arthritis of the knee, there will be a degree of upregulation. So for different people at different times, or comparing different people, you will have a different component of their pain, in part related to the degree of nociplastic component or sensitization. So the meaning of why they've got the pain, or the emotive aspects, or the anxiety state of the person at the time can change their pain level through a neurological mechanism, even though their arthritic condition or the initial stimulus may not change. The second thing we should realise is that the mechanism of pain can change during the course of an illness. So for shingles, for example, if you look at the photo there, in the acute setting, it is a peripheral neuropathic or neurogenic type pain. There's also a nociplastic component while the skin's blistering, but then eventually it becomes more of a central nervous system pathology with loss of inhibitory neurons, and it can also become a central phenomenon with deafferentation of the brain, and specifically at the thalamus. So for someone with acute shingles, it's primarily peripherally driven. With someone with chronic postherpetic neuralgia, it may well be predominantly centrally driven. And so that means that even though it's the same diagnosis and it may present similarly, the driving mechanisms during the trajectory of that pain condition can change, and it's worthwhile understanding that. We need to go to the next slide. These are 2-3 quick slides to just say the older person with pain accumulates injury. They have a different nervous system, so they're actually delayed in presenting with nociceptive pain, but then they're slower to recover. So they're slower to activate their nervous system, but they're slower to recover their nervous system. So I actually give the older person a lot more time to recover from a pain event, and I recognise that they may have accumulated pathologies, which means that they are at higher risk of developing chronic pain. We'll go to the next slide. Psychiatric illness and pain, we also need to recognise that there's shared neurological mechanisms here, so that depression and anxiety is at higher risk in those with chronic pain, both as a precursor, a risk factor, but also as a consequence of the development of pain. Those suffering pain have high levels of helplessness and suicidal beliefs, and their suicide rate is between 2 and up to 6 times higher than those without chronic pain. And then the last comment to make here is that those who present with high use opioids, I look for an underlying psychiatric illness, because there is a link in a lot of the epidemiological studies on the dose. So those that are on higher doses, or those that present with anxiety coexisting to a pathology, they get up to twice the dosing of opioids than those without anxiety or depression. And this is seen in the returned servicemen population in America, where those that have suffered significant trauma or PTSD as part of their injury, they have a much higher rate of opioid. Now, this may be because the doctors are more willing to prescribe, but it is also that they're using opioids to some degree to treat their neurological, their psychological distress. We'll go to the next slide. And then the risk there, we've just seen about the different states and how they've used the word dependence. You know, they're all using these different terms, dependence and addiction, and it demonstrates that there's quite a lot of confusion in this area. My view is that there is some shared risk factors for developing chronic pain and to develop dependence. So when you look at the chronic pain cohort, from an acute pain setting, there's up to 20% of people with chronic pain on opioids have some form of dependence or some form of demonstrating some aberrancy with regards to their medication use. We also know those with an IVDU history have similar risk factors, and they have high trauma rates, so they have also risk of developing chronic pain from the accumulated traumas. And then the third point is about the whole methadone buprenorphine treatment issue. So PBS have now said the long-acting injectable buprenorphine, the depot buprenorphine, is available for opioid dependence. So this, at a practical level, does become a treatment option for those who share opioids, chronic pain, and some form of dependency. We'll move to the next slide. So taking all those things together, this is what we often see in someone with chronic pain. You've got the tissue issues, or that trigger initially, and then you've got these layers of conditioning and events that have happened where they have cognitive approach, and there's some social responses that lead to seeing chronic pain as actually having more social and psychological aspects to it than rather than just a purely biological event. We'll move to the next slide. And that then should inform how we assess a person. So this is our simple principled sort of approach to management based on an assessment. I really want to know about who this person is and what their neurological state is before the onset of their pain. I look for psychosocial status to pick up those yellow flags that are factors that are associated with increased risk of disability, distress, and if you're really thinking about opioids, you need to be thinking about, well, what are the risk factors here that are associated with dependency, opioid dependency or addiction? Then what's the component of the mechanisms? How much of it's nociceptive? How much of it's neuropathic? How much of it is sensitization? And you base that on the pain character and the site and other factors. In the background, you should always be thinking about the red flags, so that possible indicators of serious medical conditions. And chronic pain patients, because of their high risk of comorbidities, do develop cancers and they do get complications. So it is worth revisiting their pain complaints, or when they do continue to present with their pain, it is worth revisiting your diagnosis. What's the impact at a biological, social and psychological level? And then what are you expecting? At what point are they in the trajectory? Where will they recover or not recover to when you should be potentially changing your management? When you look at the healthcare response and the solicitor systems, we're really thinking about the legal system and when do they get a settlement of their claim, for example, and often they will not settle until that's been completed. Next slide. So I use that as my basis for pain management, the principles being social, psychobiological, and the starting point is educating the patient, but also the family and the other healthcare providers. And that works at the brain level, the perception of pain, can be readjusted. And so the experience in a person of their trauma pain or their neuropathic pain can change with proper neurophysiological education. And there's a group called the NOI group that have looked at explain pain, and they've demonstrated that you can change your perception, changes your pain experience. Pharmacological principles are that opioids are for nociceptive pain, but also local anaesthetics and clonidine. Non-steroidals, antioxidants and biologics are for those where there's an inflammatory component. So if there's not a lot of inflammation, then non-steroidals aren't really going to work a great deal. Blocks, ketamine, magnesium, clonidine, tricyclics, gabapentin are really there for nerve injury pain or where there's sensitizations to down-regulate the sensitized system. Now, the non-pharmacological strategies work for both, both the nociception and the sensitization. They're not particularly good for neuropathic pain, except for maybe neuromodulation, but a lot of those other things are about reducing the sensitization and potentially preventing that chronic disease aspect of chronic pain. I'll move to the next slide. This is the basic analgesic plan, which you'd be very familiar with. I will point to meloxicam there. It tends to be in the acute setting one of our preferred non-steroidals because it inhibits platelets, but it doesn't cause increased bleeding. And then of the opioids, we do have a preference for the atypicals, tapentadol, buprenorphine, because of their dual mode of action, and they have some safety benefits with regards to mu opioid receptor issues. I'll move to the next slide. The adjuvants. Gabapentin and pregabalin was brought up as a specific point to talk about. Now, the evidence is not particularly strong, although it does reduce that sensitization component, so it works well with an opioid in acute pain and in that subacute pain, and then specifically long-term in those with chronic neuropathic components. It is a risk, though, because it's sedative. If it's with an opioid and moderate dose opioid, there can be an increased risk. And gabapentinoids have been coming through in the statistics of those related to opioid prescription deaths. Amitriptyline and nortriptyline are our preferred tricyclics, and they do reduce the neuropathic pain component and the risk from going from acute to chronic pain through decreasing central sensitization. And so you'll often see people with major traumas coming out of hospital on a tricyclic plus reducing dose gabapentin. Clonidine is used when you're looking to change the opioid dosing, blunts opioid withdrawal symptoms, and is very good for anxiety associated with opioids. So it's a medication that we really like to use. It's very well tolerated, although some patients don't like its sedating effect. I'll move to the next slide. Now, with regards to opioids, the philosophy from our perspective that opioids are anti-nociceptive, and it's really there for nociceptive pain. But the evidence is it fails. At a population level, a lot of people do not maintain their benefit opioids. And I would view this as being for four main groups or reasons. One, you develop tolerance, so the actual benefit response is flattened. But also you activate the nervous system underneath it called hyperalgesia, so opioid-induced hyperalgesia. And that's why you get myalgias or arthralgias with opioid withdrawal. The other reason it might fail is because the disease has progressed. It's more advanced cancer, there's a new fracture, or the change in mechanism. It's gone from being predominantly nociceptive to being predominantly hypersensitization, so a perception issue or a nociplastic component. And so opioids are less beneficial in that setting and may actually be detrimental. So a condition can change from being opioid responsive to being opioid unresponsive due to the change in the predominant mechanism. And then the fourth reason why opioids fail is psychosocial. Anxiety, as I've mentioned, but also misuse, diversion, or addiction. Principles of opioid prescribing is you must maintain an anti-hyperalgesic to prevent opioid tolerance and hyperalgesia developing. And paracetamol and a non-steroidal are the simple ones, but it may be opioid plus clonidine. And that atypical opioids don't have as much opioid-induced hyperalgesia over long-term or tolerance, and so they are preferred in the medium to longer term because of the synergy. We'll move through the next slide. And there's the range of full-strength opioids you'd be familiar with. There is no one agent that's preferred. Oxycodone probably is a bit cleaner and has some kappa opioid benefit, but morphine, because of its long high metabolites, can be beneficial in that longer chronic pain patient. I'll move to the next slide. This is really there for reference, but a lot of people say to me, addiction starts in the acute setting, but it's important to look at the literature and say, if there's no risk factors, the potential risk in acute pain is low. It's less than 1%. And as you go through, if people are still requiring an opioid, you should be looking at, do they have risk factors, or are they developing a lot of sensitization that means you need to be changing your opioid strategy? There's also a number of provider or system factors associated with the maintaining opioids. And so in America, it's what the healthcare system is contributing in part to their opioid crisis. There is also benefit, however, of aggressive pain management in that acute setting. So the more liberal opioid use early does tend to improve outcome, but it needs to be factored in a decreasing dose as you recover. Next slide. And in the chronic setting, I'll move past this slide actually, thank you. And in the chronic setting, it's more controversial. The population studies saying there's harm, but if you look closely at some of the prospective studies, there is benefit. And in particular, there's benefit in those with nociceptive pain. And the one there is by Krebs from 2018. From baseline, an opioid-only technique was beneficial, but it was the same as a non-opioid group with gabapentin, paracetamol, non-steroidal plus or minus tramadol. Now, ideally, you'd use an opioid plus paracetamol or an opioid plus a non-steroidal in a musculoskeletal cohort, and you can argue it's nociceptive pain or predominantly nociceptive pain. There is evidence of benefit. When you give it to a population, that benefit in that subgroup tends to wash out, and so you don't see a global benefit and you do see evidence of harm, and that's what's been driving the PBS requirement, the changes. Next slide. I'll move past this slide, I've mentioned this. So how do we also manage it? Optimal management includes multidisciplinary care, including activating a rehabilitation strategy with education, physiotherapy, clinical psychology. Problems are barriers. So the patient puts up a barrier. They're not ready to change from being a medication dependent to being self-management. There's also a lot of other solicitous systems that need to be overcome. Community services can provide this, community healthcare services. So it is very important to explore what's available in your area and open up those links and make it a loosely coordinated community-based pain program is viable in the rural area. Move to the next slide. I'll move past this. This is a comment on perceived injustice, which I think is worth looking up if you've got time. Next slide. Now, I want to just briefly summarise. In real time, this is the opioid system in Victoria, and there are systems in development in New South Wales, Queensland, WA and South Australia, all on these same principles. There's a database where both the electronic dispensing is going to go in, prescribing is going to go in, and the electronic dispensing. I'll go to the next slide, and this is what the Victorian system looks like, in that we can look up a patient and see who's prescribed, and what's really helpful is the name of the pharmacist and the phone number, and up in the top right hand corner it says alert history, search history, who has viewed this. So if a patient comes to grief, then there will be an electronic record of the prescriber and the dispenser and whether they checked the system, and that's what's going to change behaviour. This is meant to be a clinical decision support tool, but it will have a governance role, but it will be state-based. Next slide. So that means that there should be safety strategies in place for opioid use. So that should include good education and leadership and support programs for community areas, and particularly out of urban and rural areas where there's a higher rate of opioid prescribing. I believe in doing sleep studies and dental hygiene techniques for those on chronic opioids, and assessing or reviewing their hypothalamic pituitary axis because it is suppressed with long-term opioids. Have permits in place, legal, and have family engagement. rarely, but possible, you can do a blood level. If you've got patients who are drowsy, you're concerned they're opioid toxic, you can do a blood level and send it off. And then I look towards having triple diagnosis management plans, so having addiction services or psychiatric services to assist with patients with complex presentations. Next slide.
We might have to wrap your session up if that's okay. Yeah. Look, we've got a couple of questions before we go on to case histories. A relevant one to you, Malcolm, is how long would you continue with clonidine or ketamine therapy in chronic pain?
So the ketamine concept is really about inpatient care to get rapid opioid reduction into a safer level. Clonidine I will use long-term if patients will tolerate and accept it. And I'll be co-prescribing with the opioids so that they limit the risk of opioid tolerance and you get synergy between different mechanisms of action. That's a bit more of a long-term chronic pain perspective. In the acute setting, if those at risk, we use it more short-term and a matter of weeks after their acute setting to allow the opioids to wean off. So if they've had trauma, they're in hospital, I'm expecting 6, maybe 12 weeks of pain to be there. I want to get their opioids trajecting down, and I'll use clonidine through that period to assist me, get the opioids to the lowest level or off, and then I cease the clonidine over time.
Okay. What about the ketamine? How would you do that?
So you can do a burst ketamine of 24 hours, but most patients look for 3 to 5 days. You can do it in community areas in like rural things, but I would normally seek support. I've done it in my practice by liaising with the GP, sending them our policy, and they might ring me once or twice during the 5-day period. They do them in their community hospital with ketamine subcutaneously, monitored, certain dose, 0.1 to 0.2 milligrams per kilo, and use that period to dose reduce the opioid. And this is particularly for someone who's on 100 or more oral morphine equivalents per day. Ketamine can dose reduce it to 60 to 40 to 20 and then stabilize it and discharge it at a much lower dose with clonidine, for example, to maintain it at that lower dose.
Great, thanks for that. That was a good question. Lewis, how would you work out whether someone with chronic pain already on long-term opioids without being escalated is okay to have an ongoing medications, or are they likely to have drug dependence or a likely combination? And a lot of the patients that this doctor was concerned about weren't keen to hear about trying to wean or seek psychological therapies or other therapies. Lewis, what do you think about that? That had come into your bailiwick?
Yeah, and definitely that's one of the regular challenges. And when I was working in general practice myself solely, then that was something that I used to hit with patients that I inherited. In fact, one of the GPs in the town from another practice retired and sent me a whole lot of gifts of people who'd been on opiates for 20 plus years. And I think the first thing is it's about developing enough of a therapeutic relationship with the patient that you can start to have some clear discussions with them about the harms that are, the potential harm, and then look at what they're actually using the opiate for. For a lot of these people, particularly when they've been on opiates for a long period of time, there is a degree of hyperalgesia there. So they're chronically in pain, and they assume that if we gradually look at weaning off, their pain's going to get worse. And sometimes we find that if we can engage them collaboratively in a process of gradually weaning backwards, then what we find is that the pain doesn't actually get worse. And I had one guy who's found that his pain got better and became more enthusiastic. And it took several months of working with him to get him to play. So it's not an easy thing to do. I think the other challenge, particularly when you work in a small town, and I was a GP in a town of 2,000 people, is that there are all those others. You're part of the social milieu as well, and so all of those other the psychosocial factors, they're hard to extricate yourself from as a person. So I think the principles are around having enough of a therapeutic relationship with the patient that they will be prepared to engage in those discussions. And it's not sort of laying down the gauntlet, it's more trying to engage them over repeated consultations. Pointing out to them that you know, under the regulations, we do need at very least to get somebody else to see you every 12 months to confirm that this is appropriate ongoing therapy, and then starting to look at alternatives. Now that 12-month review through the federal regulations doesn't have to be with a pain service. It's just another medical practitioner, but using a respected colleague, and obviously in small towns sometimes you're the only doctor around, so that's hard to find as well. But yeah.
Yeah, no, great. Thanks for that. Well, this is probably more in your area, Malcolm. We have a question. I think you've probably already answered it earlier on in description of pain modalities. But what would you think would be a normal period for post-op pain, post-surgically, for opioid use?
So one of the slides that I skipped over was looking at the American cohort who are promoting opioid dosing, average dosing for people after random, routine surgeries. My argument would be it's about the person as much as it is about the surgery. And so understanding the person before their operation, how the operation went, and what the expected recovery would be. Now, for the older person after a knee replacement, I would expect it's going to be sore for a matter of 2 to 6 weeks, maybe longer, but there'll be quite a lot of variability there. For the younger person, it will be a shorter duration. More complex, bigger traumas in the orthopedic group, we've noted 60% of people have significant pain still at 3 months, but only a third of these are on opioids. So having pain doesn't mean you have to be on an opioid in that recovery phase. And that's where these other modalities come in, including the psychological strategies, good education, mobilisation, and use of those other medications rather than relying on opioids until pain complete resolution.
Great, thanks. What about other techniques, patients particularly with low back pain that plague us? The use of epidural steroids and analgesics, and particularly patients with metastatic back pain using syringe drivers and epidurals, etc.
So I think the whole concept of back pain is, we've been seduced by thinking, well, there's one mechanism. There's not. There's multiple mechanisms of back pain, and the mechanisms can change. I look to things such as a bone scan, if you can get hold of them, to interpret what's active at that moment, because arthritis between the vertebral bodies, I think, is an under-recognised cause of someone with chronic low back pain. I mean, you can do your disc as a 20-year-old. It's 6 to 12 weeks of back pain and it gets better. But 20 or 30 years later, you've got a damaged disc, you develop an arthropathy between that. And so that's a very hard approach to manage. Opioids could be justified if you've got clear nociceptive changes on your scans, including the bone scan. Lumbar stabilisation, posture, pacing, all quite indicated and relevant. Simple paracetamol non-steroidals where there's an inflammatory component. Now, epidurals don't do a lot for back pain, but they can be helpful for the radicular component, particularly if there's foraminal stenosis or there's clear disc injury onto the nerve. So in that subacute or acute setting, they can be quite helpful to settle down the radiculitis, but it doesn't change the primary pathology, which may well be a disc tear or a facet joint.
That's great. Look, thanks. Well, we've got about 30 seconds left. So I'd like to thank the panel, Malcolm Hogg and Lewis Christie. Thank you very much. I think you've dealt with a lot of the issues that had been posed as potential threats to rural doctors, and I appreciate that. I'd just like to remind everybody that an email will be sent out with a link to a recording of this webinar. It has been recorded, as you'll see the little red button flashing. And so we can continue. We'd like to have your feedback, suggestions, and Also, there is it's regarded as professional development time. You'll get 1 hour of learning out of this. So please give us your feedback, register your feedback. And that's probably all it for tonight. So thank you, everybody. Thank you, those that have sent their questions in and all attendees. And thank you again, Malcolm and Lewis.
No problems.
Thank you.
Good night. Thank you all. Thanks, Lex.
Cool.